Today, Dr. Ricardo Quinonez. He's the chief of the Division of Pediatric Hospital Medicine at Texas Children's Hospital. He's a national leader in the field of pediatric hospital medicine and served in the committee that applied and received recognition for pediatric hospital medicine as a board-certified specialty through the ABP. Dr. Quinonez was a committee member of the inaugural Hospital Medicine Subboard of the ABP. In fact, he holds certificate number 8 out of over 3,500 board-certified pediatric hospitalists nationally. Dr. Quinonez has served as a leader of various national medical organizations in the AAP, APA, and the Society of Hospital Medicine. Most relevant to today's presentation, in collaboration with the Society for Hospital Medicine and the AAP, he led the first group to publish a pediatric Choosing Wisely list. His main academic and research interest is in the high-value care for hospitalized children, and particularly in the overuse of medical tests and therapies. He was a founding member and steering committee member of the Value in Inpatient Pediatrics Network, which is now named the Pediatric Acute and Critical Care Network. This AAP International QI Collaborative Network focuses primarily on de-implementation efforts of non-evidence-based practices, many of which we will hear about today. Thank you.
Well, thank you so much for the introduction. I'm told I need to speak very loudly, and that's usually not an issue for me. So we'll get started. And I would say that out of all the places that I have been invited to speak to, this is always the most special because I'm presenting the work in front of my colleagues, and it's always best. And I usually get the most nervous when I do TCH ground rounds out of any presentation. And so let's get started. Nothing to disclose. I do have to disclose that, as you heard, I built my career around the issue of overutilization, which means that my views are likely biased by these academic interests, as you will probably hear. And being a student of Terry Turner, I always have goals and objectives in my presentations. And so my goal is to introduce you to the concept of de-implementation and hoping that you'll adopt that into everyday practice, and in doing so, be better stewards of resources. And here are my objectives. You all got this on the grand round announcements. I'm not going to read them. But we'll go through all of them as we go through the presentation. But we certainly need a little bit of a background to introduce the topic. And let's talk about medical standard of care. So standard of care in any profession has a standard of care. For medical standard of care, it has many definitions, but it's basically all the same. It's treatment that is accepted by medical experts as a proper treatment for a certain type of diseases, entities, and is widely used by healthcare professionals. It's what we as professionals accept as the care that patients should receive, and that we agree that is the standard that we should use. But medical standard of care is fluid. In this publication, this was published quite a bit ago, they looked at articles in a decade, from 2001 to 2011, published in a high-impact journal, Think One in New England. And it evaluated articles that tested established therapies versus new ones, i.e. they were testing the standard of therapy. Out of 363 articles which met their criteria, that tested the standard of care, 146 of them were reversals of the standard of care, 40.2%. And only 38% reaffirmed it. That means when we look at it, the vast majority of articles actually reverse the standard of care, and the minority reaffirmed what would have considered the standard of care. One of the conclusions of the authors is that most standard of care are not supported by high quality evidence and are often reversed by subsequent evidence. So the standard of care is fluid. I think we need to keep that in mind as I go through the presentation, because that is the issue. That is one of the reasons why we need the implementation. So let's define implementation first. That is just in general is the execution of a plan, idea, model, or policy. But in healthcare, it means promoting uptake of research findings into routine healthcare, whether it be clinical, organizational, or in policy context, of that healthcare. So that's implementation. In an ideal world, we would implement after robust research demonstrate the intervention of policy being implemented work, randomized control trial or some other prospective study. That is not what happened in most of the cases. All right, let's see a pediatric example of this. Neuroblastoma screening. Back in the late 90s in Europe, they decided to screen for neuroblastoma. Now, you might think, why neuroblastoma? Well, one of the reasons is because it's easy to screen for neuroblastoma. It's very non-invasive. What do? You do a urine, you test it for catecholamines, and if it's elevated, you explore some more. And in fact, they found more cancers. Unfortunately, they did not reduce the number of stage 4 cancers, which is what you're trying to do, and or mortality. So we're probably finding cancers that were inconsequential, those that would have gone away on their own. Cancers actually do that. They do go away on their own. That's what one of the functions of our immune system. Screening likely led to overdiagnosis, increased overtreatment with increasing morbidity and mortality. So we don't do this anymore. So the good thing is, yes, they implemented the screening before robust evidence was there, but then they tested it. They found the robust evidence, and we don't do this anymore. So they had to de-implement. So now let's talk about de-implementation. It has been defined as abandoning or divesting from low-value, ineffective, or harmful medical practices. Now, we can accomplish that through complete reversal. We do the opposite. Substitution, we do something else. Or reduction, we do less of it. What about high and low-value care? High-value care means providing best care possible. You have to be efficient and achieving optimal results for each patient. It is not just about cost. Often people, when you talk about these subjects, they think you're talking about cost, but it's not just about cost. Because high-value care can be vaccines, which is very cheap, or it can be cancer treatment for leukemia, which is very, very expensive, but certainly high-value care. Low-value care can also be very expensive. MRI for lower back pain or headache, or it can be very cheap, albuterol for bronchiolitis, but it's still low-value care, right? It doesn't work, doesn't give you much information. It may lead to overdiagnosis, overtreatment, etc. Most medical advances are not high-value care. That is, you'll see it all the time. Most things that we do in medicine, most new things, are usually not defined as high-value care. Here's a representation of that in a graphic form using number needed to treat. As you can see, to get to a very low number needed to treat, you need things like public sanitation, clean drinking water, vaccinations. Those are very low numbers needed to treat. You know, when you go to disease management, chronic disease management, it's a little bit higher. And then certain screening tests or MRI for uncomplicated lower back pain, they're very expensive. You know, it's grafted against healthcare spending there. And the number needed to treat can be 100 or infinitum, right? That means it just doesn't work. And we know that overuse and overtreatment happens in pediatrics all the time. And the reason I know that is because one of the things that, one of the most meaningful things that I did in my practice was to collaborate with a few people nationally on these publications. And we were modeled as an adult publication, in which we looked over the past year, the 10 top research publications related to overuse. And then we would rate them and put out and summarize the top 10. And this was our first publication back in 2016. So we were really looking at articles for 2015, 2017, 2018 on pediatric medical overuse, 2019, 2021. We kind of skipped a year because of the pandemic. And so we decided to do it every 2 years. And so 2021, we published, that was the last time I participated. And then we passed the torch on to younger collaborators, if I can say it that way. And they published in 2023, the last update on pediatric medical overuse. And in every time we published this, we found high quality evidence that highlighted issues of overuse. So we know it happens in pediatric all the time because, as you can see, I've been looking at it for over 8 years now, and we always find them. And what did they find in 2023? They found things like routine temperature measurement at well-child visits may lead to unnecessary antibiotic prescription and vaccine deferrals. 3-day course of antibiotics was not inferior to 5-day course of antibiotic for community-acquired pneumonia. That was backed by high-quality RCTs and meta-analysis. The use of proton pump inhibitors, which you all have heard all the negative consequences that can happen from long-term treatment from them, they found that may lead to higher rates of asthma. They have already been shown to increase GI and respiratory infections. And it is important to know, just like the routine temperature check at well child visits, that even sensible interventions need proof. Now, you wouldn't even think about, why wouldn't you measure a child's temperature when they come see you in the office? Well, I just showed you why, because it may lead to vaccine deferrals and other tests that are unnecessary. So even things that you think make sense, you have to prove it. And here's a great example of that. This is the H2O trial, post-discharge nurse home visits and reuse. So basically what they did is every single patient that was enrolled in this study was either randomized to having a nurse visit them after they were discharged from the hospital, or not having a nurse visit them after they were discharged from the hospital. In order to, the theory is that if you have a nurse come see them at their house after you discharge them, it's going to prevent readmissions or subsequent healthcare use, because that nurse, he or she, can answer the questions that they may have, or do some preventive care. So, but they decided let's not just do it, let's study it. And they did. And I already told you what their aim was. And they enrolled over 1,500 children randomized to nurse visit, intervention, or no visit. And what they found is that children in the intervention group, those in which the nurse went to visit them, had actually higher rates of healthcare reuse. Now you can ask, so why, right? And there may be many reasons, but the fact is that they had higher rates of healthcare reuse. So even sensible interventions need proof. And now I'm going to introduce you to what I like to call the de-implementation life cycle. And it usually starts with something new, something novel that somebody introduces. And then observational studies come out and we're like, yes, it works. We get a few observational studies that with this new test, this new treatment, this new modality of something else worked, because we did an observational studies and the outcomes of patients seem to be better. And then everybody starts using it. We just give it out, just like Oprah giving out cars. We give it out to everybody and everybody adopts it. I don't know where everybody got that, where that's like 17 years from research to, to bedside. That's no longer the case. We introduce something new and all of a sudden everybody is using it. And then somebody does an RCT and says, oh, wait, maybe it doesn't work, right? And then you get subsequent RCTs that shows it doesn't work, and subsequent RCTs, and then meta-analysis that it doesn't work. And then we have to take it away. That's where I come in. We have to take it away and everybody's unhappy. And then the cycle starts all over again. So that's the de-implementation life cycle. And I'm going to show you a real life example of the de-implementation life cycle, a very recent one. And this recent example is high flow nasal cannula for bronchiolitis, our favorite toy of pediatric hospitalists. And what we mean by high flow nasal cannula, for those of you that don't use this, is basically heated, humidified air that allows you to give higher rates of oxygen to children, therefore bypassing some of the nasal obstruction that they may have, which is very prevalent in bronchiolitis, and in theory, delivering oxygen and air down to the lungs in a more effective way. So it makes sense, again, that this should work because, you're bypassing exactly what's wrong in bronchiolitis. So it makes sense that it works. And this is sort of a setup, a normal setup for high flow nasal cannula. And it's usually used for infants less than 24 months in bronchiolitis. That's the usual use, although we do use it for other things. And in fact, Observational studies, initially, when we started using this about 10 years ago, maybe a little bit more than 10 years ago, said that it worked. And what it showed, this is one of the first studies, is that it decreased intubation rates. In this study, it decreased intubation rates from 37 to 7% over the 6 years that they were using it. Now, if you get these types of results, why wouldn't you use this? I mean, that's fairly dramatic, right? You know, from 37% to 7%. And subsequent studies showed that it decreased the use of ICU, you transfer less patients to the ICU, et cetera, all observational retrospective studies. And then everybody started using it. I mean, when I say everybody started using this. We certainly adopted this right away. Here's a study from 2010 to 2019, a 72% increase. This is a European study in the use of high flow nasal cannula. So that's the weird line that just shoots right up from 2010, that orange line, as you can see, the use of high flow nasal cannula just completely shot up. And then, of course, the RCT started coming up. Here's the last one. This is the largest RCTA, this one of many that was done. This is the Paris 2 randomized clinical trial. This is, and basically it showed all of this. All randomized controlled trials of high flow nasal cannula, single center and multi-center trials have failed to show effects on length of stay, escalation to higher levels of care, and effects on intubation rates. In fact, epidemiologic studies have shown increased admission rates to the PICU since they were introduced. So in 2010, around 2010, when it was introduced, if this worked, we would put less patients with bronchiolitis in the ICU. But in fact, when you look at how many patients we put in the ICU with bronchiolitis, over time, since 2010, we actually hospitalized more kids to the ICU since 2010. So certainly, that is a fairly bad indictment of high flow nasal cannula. And again, randomized controlled trials have shown no effect on outcomes that patients care about. So then comes deimplementation, and deimplementation of this is already taking place. Here's a multi-center quality collaborative to reduce overuse of high flow nasal cannula in bronchiolitis. Is 71 hospitals at the Deimplementation Collaborative, large children's hospitals, and non-university community-based hospitals. This was done by that group, which I used to be a member of, which a founding member of, the Value in Inpatient Pediatrics group, and 71 hospital collaborative. And the aim was to reduce high flow duration of initiation from 30%, from a 30% baseline. 13,649 unique patients in this collaborative. Several interventions, multimodal interventions, including toolkits, QI coaching, webinars, feedback, and real-time data availability, so hospitals can get their data right away if they join the collaborative. Initiation decreased 32% and duration decreased by 28% in this study. Length of stay was unaffected. Now, it would have been nice if we would have shown the length of stay decreased, but at least it was unaffected. It didn't increase, right? So they didn't put more patients in the ICU and they stayed longer, et cetera. So that is the deimplementation life cycle. And I'm showing you an example that's happening right now. And I have to say, I can't take full credit for the deimplementation life cycle. My good friend, Sean Ralston, who is the primary author of the AAP bronchiolitis guidelines, had something very similar. He actually called it the bronchiolitis life cycle because it works exactly the same. Now, in pediatrics, we often complain that we don't have good evidence like they do in adult care, right? Like we don't have as many randomized controlled trials, et cetera. Let me tell you, that is not the case for bronchiolitis. There is oodles of evidence, good, high-quality evidence, multi-center evidence for many of the things we have done in bronchiolitis, and they have been many. We've tried antivirals, bronchodilators, nasal decongestants, chest therapy, systemic steroids, hypertonic saline. Now, you know, if the mid to older hospitalists here in the room will remember that we used to use hypertonic saline like water, right? We put every single patient on hypertonic saline at some point. And because, again, observational studies, international observational studies showed that it worked, and then randomized controlled trials showed that it didn't work at all. In fact, in some studies, it increased length of stay. So we don't use hypertonic saline anymore. And of course, the newer player in the block, which is high flow nasal cannula, which I've already gone through. The implementation is hard. The reason it's hard is because the playing field is uneven, because it is much more exciting to do new things, right? Creating something new is much more exciting and people get more behind it than when you say, no, we got to stop doing something that we were doing. So it's hard. So the best thing is usually sort of prevention, right? Not adopting new things, and we'll talk about that. So how do you de-implement? Great question, because there are no well-studied approaches, even less in pediatrics. All we have is a lot of experience. Now, there are publications. This is probably the largest one of them. Everybody who does de-implementation is familiar with this study, the Neven study. And it was basically, it's a study in which they were looking at anything that had to do with de-implementation. And they were trying to find the best approaches to de-implementation. So they looked across the literature. They called it de-adoption because that's actually, if you look at old literature, that's actually the term that was used the most. And in fact, that's what they found. They reviewed 109 papers from over 26,000 citations, 43 unique terms that they found, 43 unique terms that actually meant the implementation. The most common was the adoption. Disinvest was actually also very common. And what they did is they developed a conceptual framework for the implementation. They tried to identify low-value care practices. And what they said is low-value care practices should be the heart of this framework, and that priority should be given to low-value practices with high evidence basis or high evidence of harm, or high cost or frequency. And what they said is that stakeholder engagement in any of this de-implementation efforts is key. And here, and I have some QR codes there. If you want to scan them, it'll take you right to this figure and to the paper. But they, as you see, their conceptual model was one in which the stakeholder engagement was right at the center, right? It's very important, and we'll talk a little bit more about that. You have to identify, prioritize low-value care clinical practices, and once you do that, you start a cycle, but this time it's the cycle of de-implementation. You have to show that you can sustain it, assess it. You have to adapt the knowledge to local context. Very important to do that because every culture is different at every institution. And so you do have to adapt to local knowledge. This is sort of the same framework that we used in the Value and Inpatient Pediatric Network. And it seems to be very effective. But stakeholder engagement is one of the most important things. Now, there is a consolidated, the implementation scientists have a lot more robust evidence as to how to implement, and they're very effective, as you can see with high flow. They'll implement things right away. Complementary model for the, it really, while this provides the framework for effective implementation, it also talks about de-implementation, right? De-implementation is not just implementation in reverse. It uses some of the same principles as implementation, right? And this framework, which again, you can go to with the QR code, is particularly useful for identifying barriers. This is their website is under construction, so I couldn't find it. I couldn't give it to you, but this is the Value and Inpatient Pediatric Network. It's now called the Pediatric Acute and Critical Care Quality Network. It's an AAP QI collaborative for implementation and de-implementation, although most of the work that they've done is on de-implementation. It was called the Value in Inpatient Pediatrics, but now we include ER, critical care. That's why they changed the name. It's the Acute Care Network, Acute and Critical Care Network now. And it has done very large QI collaboratives. And the strength of this network has been the inclusion of community hospitals. And why is that important? Because now we sit here in the largest children's hospital probably in the world, but most children in this country do not seek care in large pediatrics hospitals. Most of them are seen in community hospitals. That's where most children, in some studies, close to 70% of children actually, when they sought hospital care, went to community hospitals. So it is very important to include them in research, but often they're not. right? Because often these are not places where a lot of academics takes place. But the VIP network has shown that you can actually engage these community hospitals. That's why you see these large collaboratives with 71 hospitals. There's collaborators that have 106 hospitals in them. And there's some of the names. We're very good at engaging community hospitals. The other thing we're very good at is coming up with catchy acronyms. High flow, basic, SOFI, PIPA, revise, the fever one. Everybody knows revise. You're a hospitalist. So we're very good at coming up with catchy acronyms, which, you know, it's important. Everybody wants to be part of an acronym that sounds really cool. And they have been very effective. In fact, if you look at the May issue of Pediatrics, they basically owned that issue. Every single publication of quality reports was a VIP publication. Here's one of them, where they were trying to improve guideline concordance for the febrile infants. So concordance with the new AAP fever guidelines, 17,000 infants included, 103 hospitals. And basically they showed that they could increase adherence to AAP CPG guidelines, and some over 90% adherence. And usually this adherence to AAP guidelines means doing less, right? Like not getting an unnecessary LP, not getting an unnecessary lab. That's usually what it means. There are some implementation efforts there as well. It's not fully de-implementation, but usually when you're trying to get people to comply with a guideline, it's not usually things that they're not doing. It's usually things that they're doing too much of. And that's exactly the case for this. And this is a national quality improvement collaborative to improve antibiotic use in pediatric infections. So the right antibiotic for the right infections, the right spectrum, et cetera. This was the basic collaborative, 118 hospitals, and they improved adherence to appropriate antibiotic use for community-acquired pneumonia, UTIs, skin and soft tissue infections. And they showed an overall improvement of 13%, which doesn't seem that impressive. When you're talking about 13,000 patients, that's a lot. So it really is. And most importantly, no change in balancing metrics, escalation, revisits, or readmissions. And then I already went through this QI collaborative for the high flow, which I showed you in the life cycle of high flow. That was very, very effective in decreasing the use of high flow and initiation of high flow. Here's one that we are participated in. This is Texas Children's data from here. Dr. Lisa Beckner actually leads this for us. We're part of this collaborative. It's called the EMO study, or Eliminating Monitor Overuse. It's a multi-center de-implementation QI project focused on reducing pulse oximetry overuse. Basically, what they're trying to do is patients who are not on oxygen decrease the use of pulse oximetry, because it can lead to it's been shown to lead to increased length of stay, unnecessary length of stay, and putting them back on oxygen when all they're doing is really sleeping and have, you know, a normal, what could be considered a normal O2 sat. And when we first started, we saw that we had a 34% overuse across all three campuses. All three campuses, which is another important part of VIP, is they usually, if you have community hospitals within your network, they ask you to include those, and we did. And our goal was to reduce 34 to 17%, and it actually dropped to 11.5%. So we exceeded our in phase one, but of course you have to maintain it, right? So phase two, this was the active de-implementation phase. Phase two is more of a sustainability phase, and now our overuse is at about 20%, so almost to the 17%, but you do have to monitor whether you can maintain it, and they're currently analyzing phase three data, and we'll see where we're at after that. But so I'm going to talk to you now, because there's not much data as to how to de-implement. I'm going to talk to you about my personal experience and things that I've learned across the years of having done some of these projects and been involved in some of it. Is that you have to choose interventions that have high evidence basis of futility. For us as pediatric hospitals, that almost always includes interventions from bronchiolitis, right? So high evidence of futility. This was actually the first VIP publication, a while ago. I don't even remember what year. I still had more hair. And it was, again, a multi-hospital collaborative, and we showed that we could reduce the use of unnecessary things in bronchiolitis, such as bronchodilators, steroids, etc., in a significant way. But you don't have to have high evidence that something doesn't work. You could also target things that have low evidence that they do work. So, for example, pulse oximetry use, the one that I showed you, there's not much evidence either way, whether using pulse oximetry in certain patients is a good thing or it could be a bad thing. There's not much evidence either way. So you could target that and see and monitor what happens, which is exactly what they're doing in the EMO collaborative. This was another sort of single center study where they used as inspiration one of the choosing wisely recommendations that we put out that you heard about in my introduction, where we were saying don't use pulse oximetry on patients that are not on oxygen. And they tried to do this and were very effective. This was a single center study in Cincinnati, and they were very effective at being able to decrease it. Speaking of oxygen saturation, what is the best target for O2 saturation in healthy children hospitalized for a respiratory illness? When I first started, 94%, as a resident, maybe student, 94% seemed to be sort of we need to keep patients at or above 94%. And then somehow 92% came into the picture, patients with asthma in particular. You got to keep them above 92%. And then the bronchiolitis guidelines came out and said, nope, it's actually 90%. So it's gone down over the years since I've been in practice. And 90% seems to be what everybody accepts in healthy children, previously healthy children who are hospitalized, who need oxygen. And there is some some randomized control trial in the PICU literature right now that suggests that lower targets may be associated with better outcomes. So those kids in which you actually target their oxygen saturation, who are intubated usually, and you target their oxygen saturation to be in the lower range, 88 to 90%, they actually have been shown to have better outcomes. That's been already shown in adults. There are ongoing trials right now to show that in children. This is one of the first. And they showed that there was better outcomes in 30-day mortality for children in which you target more conservative oxygen targets rather than liberal oxygen targets in the lower range. But what about non-critically ill children? Currently, guidelines for bronchiolitis recommend 90%. We know through the famous CHIME study where they put pulse oximeters on healthy children. We know that hypoxia, or what we call hypoxia, is common even in healthy children, and more when they sleep, right? You've seen it in the hospital. Patient is on oxygen, off oxygen all day. They stay another night, and then all of a sudden they put them back on oxygen because they're asleep, and they drop to about 88, 87%. So you've seen that, and we know that happens in just healthy children. So what these investigators decided to do is, well, why 90%? Let's just do 88%, right? And so, and these are investigators next door. They did this at UT next door. And what they did is 1,389 patients pre-post retrospective analysis in previously healthy infants less than 24 months old that were admitted for bronchiolitis. All they did was change their clinical pathway. They used some evidence that was published to justify, say, well, we're going to change our bronchiolitis guideline to say that you can go home if you can maintain an oxygen saturation of 88%. That's all they did. Two numbers. Pre-intervention median length of stay was 48 hours, which is a little high. Actually, our length of stay is actually better than that. But they did show that their post-intervention length of stay was 41 hours. Now, that might not seem a lot, but decreasing 9 hours across 1,389 patients is a lot. Is a whole lot. And that's pretty good. And so they showed that they could decrease in length of stay. And there was no change in readmission or transfers to higher level of care. So it seems to be safe, right? Now, this is a pre-post study, not great evidence, but there's some evidence. And certainly the next thing would be to do a randomized controlled trial, which actually people have done. There's a study out of England which showed that lower oxygen targets around 90% were associated with better outcomes. So there is some randomized controlled trials showing that this could be effective. And so, just remember, 88% is probably okay. So to continue, Let's do a local example that we did here of one of these things where there's low evidence basis of effectiveness. No evidence either way. So most published guidelines for asthma recommend to discharge patients once you hit an albuterol interval of Q4-hour treatment. So that's, you've heard that, right? Maybe some of the newer residents have never heard this because we changed it, but it used to be Q4-hour treatments. Where did that come from? Somebody made it up. So literally, I think one of the first few published CPGs on asthma, inpatient asthma, we're talking about inpatient asthma. If you look at the national guidelines for asthma, it doesn't include many recommendations for inpatient. So basically, people have to take those guidelines and sort of make up inpatient guidelines, right? And so a lot of the evidence that shows in inpatient guidelines that everybody adopted, I think, probably Cincinnati was one of the first, and then everybody sort of copied that one, adjusted it to their own local area. But everybody seemed to be very consistent with Q4-hour treatments. That's what we do. Once you hit Q4-hour treatments, now some people did Q4-hour times 1, others did Q4 hours times 2, others did Q4 hours times 3, So there was some modifications, but Q4 seemed to be the thing. So we decided to change things. Why not just send them home when they hit Q3 hours? That's all we did. And that's what we did. And we published the results. Dr. Wayne Lowe led this study. And the intervention, we changed the guideline here at TCH to Q3 albuterol as a safe goal for discharge. Our goal was to decrease discharge length of stay by average of 14 hours. We had some balancing metrics, right? We wanted to make sure kids didn't come back to the ER more often or readmitted more often just because we did that. So those were our balancing metrics. The results would decrease median length of stay from 36 to 30 hours. So 6 hours, right? There was no difference in readmission or ER revisits. And here's our plot showing our length of stay. And we showed that we could sustain that over the years. And again, if you hit the QR code there, it'll take you to the paper. And I would say, I've been involved in many publications. This is probably one of the most rewarding ones because I had people come to me when I go to national meetings and say, hey, we changed our guidelines to Q3 hours, based on the paper, based on this very minor intervention, no evidence one way or another. But again, no evidence that it worked the other way, right? And so we decided to target that. And so that it's been very meaningful because slowly you'll see national guidelines probably start adopting this. And I'm pushing for Q2 hours, and we'll see. Maybe next time I talk to you, we'll make that. So some other lessons learned. Like I said, choose interventions with high evidence of futility or little evidence of effectiveness. Dr. Ila Singh did an intervention here in which she targeted high frequency or high costs. Vitamin D 25 hydroxy versus vitamin D 125 dehydroxy. Which one do you choose if you want to look at the levels? It's the first one. If you choose the second one, it's very specific. It doesn't tell you anything about vitamin levels. It's used, like endocrinologists use this to explore something. I don't know what, but it's very, very expensive. And the problem is that when you type this vitamin D thing here at Texas Children's and Epic, both of them came up. And if you didn't know anything, you would just choose one, right? And a lot of people chose the other one, the vitamin D 125 dehydroxy. So what did Dr. Singh do? She just changed the name to vitamin 25 hydroxy for deficiency, right? So now it tells the clinician, this is the one for deficiency. And she showed that there was a significant decrease in the use of that laboratory, vitamin D 125 dehydroxy. And so now a lot of people are sort of copying this. To make sure that clinicians choose the right one, because not only were they spending more money, they were getting a lab that didn't even do what they wanted to. You have to engage all stakeholder and create champions to deliver the message. It is very different if I come to Dr. Silva's division and tell him, hey, you're doing too much of something. Then if Dr. Silva goes to his division of pulmonary and tells them you're doing too much of something. You have to create local champions to deliver your message. That's certainly one of the things that we've learned across the years. And if you focus on harm prevention, people will really listen to you, right? Like we're not just doing this just to not do something. By definition, if you do something that doesn't work. The only thing it can create is harm, right? And always have balancing metrics. Don't improve things for improvement's sake. This is what these investigators do. A collaborator and I actually wrote a commentary about this paper, or not a commentary, a letter to the editor about this paper. And here, what they were trying to do is they were trying to adopt the guideline, the national guideline that recommended blood cultures in children who are admitted with pneumonia. Now, their previous recommendation for this institution was that you should only get blood cultures for pneumonia for patients who have complicated pneumonias, right? And that actually was working very well. So if you look at their post-pre data, they actually had a low number of false positives and a higher number than I've ever seen of true positives, right? And then they decided to apply the guideline, which unfortunately, the evidence basis for that recommendation was very low. It was almost expert consensus. And they decided to apply the guideline. And they made things worse. They actually, they found more blood cultures, but they were probably inconsequential and they weren't true positives. So their true positive rate actually decreased. And so we sent a letter to the editor. They responded. They didn't agree with us, but but okay, don't just improve things for improvement's sake, right? Because you actually can make things worse. So why do it? Well, I talked a little bit about it. Harm prevention. Unnecessary interventions, by definition, can only cause harm. Now, the harm can be direct, radiation from unnecessary CT, or Steven Johnson because you prescribed an unnecessary antibiotic. It's fairly dramatic. It's not very often that it happens, but it can. So that direct. Most often, the harms are indirect, such as cost or missed work. You did an unnecessary test, child stays an extra day or has to go get more tests, so parents miss work and make less money, etc. So there can be indirect harms, and those harms can be long-term, right? And it is very important to sort of focus on that no intervention is benign. And people, when they talk about the implementation, have focused on ethics. Here's a paper in which the authors argue that unnecessary care violates principles of non-malfeasance. So it has to do with ethics as well. It can impact vulnerable populations more. So there's an equity lens to this as well. Unnecessary. So here's a quote from that paper, and is that certainly waste due to overtreatment harms our society. It has been described as a violation of the principle of justice under the premise that every system has limited resources, and any wasted resource necessarily means those resources will no longer be available for use by others in need. So it does have an ethical and equity lens to it that is important to focus on. So every single time you do grand rounds, at the end when you have to evaluate it says, what changes are you going to make in your practice? So I'm going to give you a cheat sheet for that. The best implementation is prevention. And the prevention principles means, I know that everybody loves to be an early adopter, but don't be an early adopter of most things when it comes to patient care. Wait. Early adoption is not always a good thing. Most innovations in medicine are not high-value care, right? It is difficult to have an intervention in medicine, that's high-value care. We do have them. There's certainly things that have made care of children much better, but the majority of them don't. Study everything. You don't have to do an RCT for everything, but at least study outcomes, right? If you do something, at least study the outcomes. So those are some of the changes you can make in your practice, but start with low-hanging fruit. Unnecessary laboratories. Evaluate panels that you use all the time, because that panel is a battery of laboratories. It may include things that you no longer need, but nobody, that you just leave. We just usually leave them there, and we just do a lot of panels for whatever you do panels for, whatever a specialty you are. Just evaluate them every once in a while and make sure you actually need everything. Pre-procedure laboratories are often unnecessary for healthy children. There's been a lot of data in the surgical literature showing that they don't do much. So if you are in a subspecialty or a specialty in which you do a lot of pre-procedure labs, evaluate the need for them. Talk to your surgical colleagues or your anesthesia colleagues. Do you really need this? There's lots of evidence showing that it's really futile. Antibiotic stewardship, focus not just on not using antibiotics, but if you do use them appropriately, focus on the spectrum and duration, right? That's also part of antibiotic stewardship, is not just not using antibiotics. You also have to look at the spectrum and the duration of antibiotics. 5-day treatment is often very effective. And in fact, if you didn't know it, you just changed our TCH, community-acquired pneumonia guidelines, to say 10 days of treatment. Now it says 5 days of treatment for uncomplicated pneumonias. So pay attention to that because we just changed this. It just went out, right? Based on published evidence. Now, I showed you some evidence that even 3 days may be effective. So next time, again, I talk to you, maybe we'll go to 3 days. But right now, our evidence-based guidelines say that that use 5 days. And small things matter. I showed you that publication or overuse, that temperature measurements at well-child visits may actually lead to harm. Now, that's a small thing, but it actually may lead to harm. So look at the small things in your practice and see if you can change them. And constantly reevaluate the fluid, right, that I showed you, standard of care. And again, I have to repeat this. There are no benign interventions. Everything we do to our patients is an intervention. Everything, right? From the moment we walk in the door to the moment we leave, everything we do is an intervention, and every intervention has a potential harm. And to bring home that point, I'm going to show you one of my favorite papers. Very simple paper, but one of my favorites. And it's the benefits of strict rest after acute concussion and randomized controlled trial. This is a randomized controlled trial of telling patients, you have to go rest, or telling them, you can just resume usual activity. They were randomized into rest or usual activity after a concussion. 88 patients completed the study. Outcomes was reported self-duration of symptoms and neurocognitive outcomes. So they did neurocognitive tests on both groups, right? A few months after the intervention, they did neurocognitive tests. No clinical significant difference in neurocognitive or balance outcomes. So both patients were fine from a neurocognitive and balance outcomes after the intervention, right after they randomized into one group or another. But very importantly, the patients that were told to rest had less school attendance and some self-reported longer duration of symptoms. So the patients that we told them to go rest were sick longer, right? That is now, can you think of a more benign intervention than telling somebody to go rest? It's probably the first recommendation that a doctor ever made. Is some patient came sick and they said, you need to rest, right? That's a very simple intervention, what seems to be very benign, but in this case, even rest was an intervention and it can cause harm. And so with that, I'll end it with one of my favorite quotes from Sir William Osler. One of the first duties of a physician is to educate the masses not to take medicine. Thank you to all my contributors who contributed some of the data that we showed here and inspired this presentation. Thank you so much. Happy to take any questions. I know there's maybe some in the chat. Dr. Nickham.
So we live in a time where people tend to not be moved by data and are influenced by emotions and stuff.
Yeah.
And you have this bias towards action. And it seems like you're asking us to, instead of don't just stand there, do something, you're asking us to don't just do something, stand.
Great quote.
How do you get that message out to, because this might be an active audience, general pediatricians, the community at large.
So I'm going to repeat the question. So how do you get this message out to general public, pediatricians, out in the community, et cetera, et cetera? Because, people sometimes are more driven by emotions than data, and that's very true. I think one of the things that I talked about was to focus on harm prevention. It's a very effective message. If you explain that an unnecessary intervention, well, first you have to get people to agree that the intervention is unnecessary. That's why you have to reach out to stakeholders that are within their own group, their own culture, and then tell them, convince them that it's an unnecessary intervention, and then have them deliver the message and focus on harm, right? By definition, an unnecessary intervention can only cause harm. And I think if you focus on that, the VIP project has shown that it can be the VIP collaborative has shown that it can be very effective. And one of the things that I would say is don't focus on what patients on, don't try to put the blame on patients. That's very important. There's a few publications out there that have shown that usually it's when our goals misalign with doctors and patients that things go wrong. And it's usually not the patient's fault. Focus on what you can control, when physicians can control. Don't blame the patients. That's not the patients who are asking for the labs all the time. It's usually the physicians, right? Yeah, we tend to blame patients sometimes, but that's not good, something good to focus on. We should focus on our own behaviors, our own practices. Any other questions?
Question in the Q&A, it says at Georgia Park, what is the strategy to address the logic of, although high flow has not been shown to be effective in bronchiolitis, it may work in the patient in front of you?
Yeah, so it's very difficult. So what is the strategy? Because sometimes when you see studies, right, that shows something doesn't work, then you have a patient in front of you in which you want to do something, right? And then you want to try it because it might work. And I would say it's okay. I would say it's okay to try things, right? But again, focus on outcomes. If you decide you want to try it, focus on the outcomes of the patients, right? And see whether it works or not. Deimplementation is not usually taking everything away. There may be a subset of patients in which the high flow may work, maybe those with really severe respiratory distress. And if you, what we decided here is that we use our CRS score, right, as a guide. Our CRS score, clinical respiratory score, has been somewhat validated in the literature. And we have decided that you shouldn't even consider high flow unless your patient has a CRS score of 7 or higher. So what I would say is if you decide that you want to start it, you want to use some objective data to say that the patient needs it, not just I feel like they need it, right? And here, the objective data that we have is our CRS score. Now, having said that, even the CRS score and any clinical respiratory score can be biased, right? It's a human that's actually doing the rating, right? Maybe if we get to the point that AI can do it, maybe it'll be more precise. But right now, it's humans doing the rating, and it can vary. But at least if you have some objective data to start something, then I think it's okay. And here we do a CRS score of, I believe, 7 or higher is when we should consider starting high flow. But we don't, because last time we looked at the data, 70% of patients to Texas Children's were admitted with bronchiolitis, were admitted on high flow, and 70% of patients do not have a CRS score of 7. So we're doing too much.
What would be your recommendation on therapies that are done on uncommon group of patients, uncommon diseases where everything's driven by expert opinion and driven through time and years because that's the way we've always done it.
Yeah.
But unsure if it's helpful or even harmful, and sometimes it takes years for that to even be evident, and the quantity of evidence is very low. When you're talking about common diseases, it's easy to generate data, but when you're talking about a small group of patients, how do you approach it?
And usually the treatment, so Dr. Silva asked, what about patients in which the disease is not that common and it would take years to generate data to show whether something is effective or not? And usually for those patients, those treatments are even more expensive, right? And harder to get. And yeah, I mean, there's not much I'm going to be able to tell you on that. We tend to focus on high frequency. Like I said, one of the things that we said to focus on is high frequency things. But what I would say is even in those patients, you can monitor outcomes, right? Yes, the outcomes may be long-term, but there are maybe some short-term outcomes, right, that you can monitor in those patients. And one of them actually that has been fairly validated is quality of life. There are very highly validated surveys out there that you can administer to patients pre-intervention and then administer it a few months after intervention to monitor whether whatever you're doing has improved their quality of life. Quality of life is one of those outcomes that we usually don't measure, but it's an important measure. I think Seattle Children's, Rita Mangione Smith, was an investigator there. She did a lot of studies looking at quality of life for every single patient that was discharged from that hospital. And it really produced some very, very impactful data showing that some interventions had no impact on quality of life, and some of them have very high impact on quality of life. And some of those interventions were actually decreasing use of certain things that had, and it showed that quality of life was affected positively or negative, depending on the intervention. So that's one of the things that you can monitor, but it's hard. Yes, when it's a low frequency disease patients, it's going to be harder, but there are things you can focus on and maybe consider using those surveys for quality of life, I think would be good. We don't do that often enough. And really that's what we're trying to do when we're caring for patients, is improve their quality of life in the end. Yes, sir.
This is great work on the inpatient side, and we see real life at apex of the curve.
Yeah.
Is there work going on ER
Mhm.
outpatient side?
Yeah, so that's why the name of the VIP changed, is because now we're including they've included ER. A lot of the studies that I showed actually had some ER outcomes, specific outcomes. So you could argue that's outpatient or is right at the cusp of inpatient to outpatient. But the next step is to include maybe maybe practices, right? Particularly when it comes to things like the fever guideline and things like that. So some work is being done. Unfortunately, we're hospitalists. And so we tend to focus on the inpatient side, but it has been expanded to at least include emergency medicine. And I think they've done some really great work. Thank you so much.